Yes. Can you see the slides?
Yes, very nice.
Okay. So today we are talking about the route map to successful extubation. As a neonatologist, it is the most challenging task that you may encounter in ICU. When you have infant on mechanical ventilation, especially the very premature infant, it is really a challenge to make a decision to extubate the infant, especially those on significant support as pressure or oxygen, and those less than 25 weeks gestational age. The graph that you can see in front of you, it is based on EPIC. EPIC data is the data collected by the Canadian Neonatal Network. And EPIC is a designed program in Canadian centers to optimize care in NICU. This evidence-based practice with quality assurance. So that's like the abbreviation definition of EPIC. So the collected data between 2013 and 2017, as you can see here, over 4 years, you can see the gestational age between 22 to 25 weeks in red and 26 to 28 weeks in blue. There is no change in the rate of chronic lung disease or BPD. There is no any improvement, although there is advances happening every year in the term of mechanical ventilation, also advances in early diagnosis of chronic lung disease. Now we are using lung ultrasounds, so we can predict chronic lung disease very early. One of the reasons why there is no significant change in outcome, the number that we are resuscitate now for 22, 23 weeks is much higher than before. And that might be one of the reasons. So we consider now more resuscitation chance for 22, 23 weeks, which was not the case before 2017. So that increased a challenge to NICU team to care of this group. Between 26 to 28 weeks, it is less a challenge and much easier to extubate and ventilate, and the chance of chronic lung disease is much less. I mean severe chronic lung disease. To protocolize everything in NICU, we should have a target for everything we do. So if you have infant on respiratory support, you should have very precise target, because considering these target values will help you to make a decision for weaning mechanical ventilation and extubation. So generally, we are targeting CO2 between 40 to 65. So it depends also if the infant on really high setting, you can wean even when the CO2 is in 60s or high 60s, because your target to extubate sooner. If you are maintaining ventilation and you don't have a plan to extubate, then you can accept between 40 to 65 as a CO2, as you can see in the target circles. The target saturation, we are using 88 to 92 in most of Canadian centers. There is misleading happen, unfortunately, from the American study that highlighted higher number of deaths if you are targeting less than 90%, which was one of the most misleading studies done, and that affected most of the NICUs all over the world. And by accepting 90 to 95 saturation, that will increase more risk of ROP and more risk of brain impaired development or impact on the brain development. So we are using 88 to 92 saturation until corrected age of 32 weeks, and after that we shift to 90 to 95. So it is more like physiologic target. We are using near-field spectroscopy for all preterm infants less than 27 weeks, at least for the first 3 days of life, or until they are more stable. So now near-field spectroscopy is the 6th vital sign being used in a lot of NICUs. We are using target pH 7.2 to 7.24. You don't have to accept higher and lower pH. That will allow easier oxygen delivery to the tissues and less chance of escalating ventilation unnecessarily. If the infant on invasive ventilation, usually we target hemoglobin, especially for the first week of life, to be more than 120 milligram per liter. Now let us talk about the specification in gestational age. Not every single premature infant is the same. So as you can see here in front of you, we divided the group into 22 to 23 weeks. They have a special specification about management, not the same like other premature infants. So 24 to 26 weeks. They may develop moderate respiratory or moderate chronic lung disease, require moderate respiratory support. Moderate respiratory support, low setting, high frequency, or conventional ventilation. 22 to 23 weeks, by default, we are using high frequency ventilation for all of them at birth. 27 to 32 weeks, usually the first intention is non-invasive. And most of them, more than 90% of them now, they are managed with non-invasive ventilation from the first hour without need for mechanical ventilation. So we're talking about the delivery room, roadmap, and then I will show you the roadmap for each one of them separate until they reach 32 to 36 weeks corrected, which is the age that we may try to consider shifting the infant to non-invasive ventilation. So first, let us talk about 22 to 23 weeks, the group borderline viability profile, the group that we discuss with parents. If they are really interested in considering support with understanding the significant impaired outcomes in different aspects, including chronic lung disease, need for home oxygen, need for home nutrition support with the gastrostomy tube, for example, and also the more than 50% chance of neurodevelopmental delay, at least from mild up to severe neurodevelopmental delay. So for this borderline viability, we have certain conditions to consider to resuscitate them. For 22 weeks up to 22 plus 6, the conditions that we consider in our center, the baby should be born in the tertiary center. We don't accept resuscitation if the infant born outside the tertiary center. Should be single, not multiple delivery, not twins or triplet. I'm talking about 22 up to 22 plus 6. Should mom before birth? There is no chorioamnionitis. There is no other perinatal risk factors that might impact the outcome other than being very premature. If the family accept resuscitation with all of these conditions, we resuscitate 22 up to 22 plus 6. 23 is still borderline viability. Also, the family should accept to resuscitate. And then we resuscitate by default without these conditions from 24 and above. This is a policy in Canada or North America. The issue in 22 to 23 weeks, we have structural deficits. There is no alveoli to start with. The lung is just sacs, big sacs. There is no blood-brain barrier. All of these conditions should be kept in mind. So whatever you give will not be protected through blood-brain barrier, will be passed definitely to the brain. Any medication you give, anything you give will affect the brain. There's high risk of certain things, suprarenal dysfunction. Almost 100% of them, they don't have suprarenal gland reasonable function. That's why most of them, they require steroids from the beginning. PDA, usually they have significant shunt through the PDA, maybe pulmonary hemorrhage, brain hemorrhage, IVH, air leak syndrome, which will be our target to discuss today, metabolic acidosis from the beginning and the development of PIE, pulmonary interstitial emphysema. So we'll divide the roadmap into the first 72 hours. What we should do in general, the default management, mechanical ventilation by default for all of them, high frequency ventilation. We are not using conventional for this group. From the delivery room, we have the high frequency ventilation ready. In North America, we are using high frequency jet ventilation, which is the most gentle ventilation modality in the world. It is not available in Europe or Middle East because it is very expensive to care and needs a respiratory therapist, which is a default present in all of the North American centers. There is no any tertiary center and even level 2 centers without a respiratory therapist, which is not the case even in most of the European countries. That's why high frequency jet ventilation only available in US, Canada, and Australia. Nowhere else. But we are just as a kind of comparison, we'll discuss that with you. Hopefully, maybe in the future, you may have it. So high frequency ventilation is the default at the beginning. We do frequent blood gases 4 to 6 hours because the most common reason for development of brain hemorrhage or IVH in this group is fluctuation of CO2. Not fluctuation of anything else. When the CO2 spike between low and high, you will get the IVH developed during this very critical period, the first 3 days. We may consider hydrocortisone similar to Premolot protocol for the first 10 days of life with any borderline blood pressure. Not all of them, but most of them. Any borderline blood pressure, significant worsening lung disease requiring very high setting, or with significant hemodynamic instability, low urine output, or as I mentioned, low blood pressure, or worsening or near-field spectroscopy. We monitor them by NIRS, monitor the blood pressure invasive and CO2. If you have the ability to do transcutaneous CO2, that would be perfect. And now the new machines for transcutaneous can be used at any age. They are very gentle on the skin. And also near-field spectroscopy can detect any significant change in the carbon dioxide because carbon dioxide is brain vasodilator, so you'll see the NIRS number higher. And washing CO2 is brain vasoconstrictor, so you'll see the NIRS, the brain saturation lower. So if it happens, on NIRS, we can detect that the CO2 now is fluctuating. We need to do blood gas sooner. We finish with the first 72 hours. Now we'll move to 7 days. The infant still on, for this group, requiring high frequency ventilation. In some very minor cases, we may consider nasal high frequency instead of high frequency invasive, or NAVA, if you have NAVA. But most of them, I'm talking about minority, most of them, they require high frequency for longer period, for maybe up to 4 to 6 weeks. And it is preferred.
Extensive cyst.
Sorry?
Observing cyst is important. You can see it is extensive cyst. That's a great thing.
Is this a question?
No question, Dr. Yasser. Someone is unmute himself. Dr. Yasser, we cannot hear you.
Yes, because you muted me.
Oh, sorry. Okay.
Okay. So in this group, if any one of them extubated, which is really unlikely, we prefer to keep on nasal high frequency, non-invasive high frequency, or use NAVA, and reassess for steroids if needed. Definitely, almost 100% of them require steroids, and we consider steroids, I mean dexamethasone, because hydrocortisone can be started early, but dexamethasone should be avoided during the first 7 days, but beyond 7 days can be used. And usually they require more than one course of dexamethasone, up to maybe 70 days of life. Now, I'm not talking about DART. DART is now, it is very mild dose of dexamethasone, is not really effective. We are using at least moderate dose of dexamethasone now. we are using beyond DART protocol. And I will show you, I have a protocol available online on our website. I can show you that to you at the end of the presentation. Now let us move on, 24 to 26 weeks. There is no default need for high frequency ventilation at the beginning, but some of them may require high frequency, at least for the first 3 days or the first day or two, and then shift to assisted ventilation. But there can be an assisted controlled ventilation from the beginning. They may need sodium acetate for significant metabolic acidosis. We monitor also them on NIRS, frequent blood gases. All of the LGAN babies less than 28 weeks, we do frequent blood gases during the first 3 days of life. Again, the most contributing factor for development of IVH is fluctuation of carbon dioxide. In this group, we expect suprarenal dysfunction, PDA, pulmonary hemorrhage, brain hemorrhage, IVH, metabolic acidosis, and maybe BIE, but not as severe as the first group. At 7 days of age, you may consider extubation, elective extubation. For cases that are unable to extubate, you may consider steroids. You need to reassess for steroids, but you can use, instead of CPAP, most of them, to be honest, we are using NIBBV. In our center, the default is nasal high frequency. We respect high frequency in our center, probably more than any other modality in this group. So even after extubation, we use non-invasive high-frequency oscillator. Other centers, they are using NAVA, which is also available in some centers in Europe and Middle East. If you're unable to extubate, again, consider steroids. If the infant stayed intubated until corrected age, 31 to 32 weeks, don't wait for steroids, because beyond that, the steroids will not be effective. So you have multiple cut lengths to consider steroids. Beyond 7 days, if the infant stayed ventilated and for any reason, don't wait beyond this period to consider steroids. Otherwise, the lung will be fibrotic and unlikely to respond. Beyond the 27 to 32 weeks, just for comparison, because now we are focusing on the more vulnerable group, less than 25 weeks. Usually this group, to start with, they can tolerate first intention non-invasive. Even we have seen 26-weeker, they tolerated non-invasive from the first day. Unlikely below 26, I haven't seen less than 26 weeks, stayed on non-invasive, tolerated well without any issue. But we have seen 26 weeks required mist, almost 100% required mist, at least 1 dose, and then non-invasive ventilation, either CPAP or likely NIBBV. They may require echo early because the PDA might be significant, and if they are on non-invasive ventilation, they may not tolerate the PDA shunt. So the first 72 hours, the first intention can be non-invasive plus mist. At 7 days, if the infant with mild lung disease, nasal CPAP is fine, but they may require NIBBV. So likely here is nasal CPAP. And likely means like more than 2/3. 1/3 may require NIBBV or nasal high frequency in our center. If the infant up to 2 weeks or 4 weeks of age and still on significant support, either invasive maybe or likely may require intubation, instead of waiting until fully intubated, you may consider steroids. If the infant really stable, very stable in CPAP, requiring CPAP of 4 or 5, room air and doing fine, you may consider transition to high flow nasal cannula, heated, humidified, high flow nasal cannula. Don't consider that before 32 weeks. Don't wean off CPAP before 32 weeks. The lung might decompensate, might collapse. 32 weeks and beyond, then you may consider in some cases to shift from CPAP to room air or to high flow nasal cannula, not before that. Let us now shift to high frequency ventilation and discuss the physiology or the physiologic need to high frequency ventilation. So as you can see in the graph here, we have the volume that we are targeting and the pressure. So the higher pressure needed to deliver the volume, you have compromised lung. On conventional mechanical ventilation, you need higher volume, and definitely if the lung is decompensated, you need higher pressure. The idea of high frequency, we are delivering very tiny, small tidal volume, very small tidal volume, less than the dead space. That's why we are not expecting volumetrauma in this group. And this is really devastating in infants less than 25 weeks, and particularly less than 23 weeks. And usually the tidal volume is around 1 to 2 ml per kg, which is definitely less than the dead space. So the difference between the mean air pressure and conventional ventilation, it is fixed. Conventional ventilation, you have fixed mean air pressure and fixed fluctuation. There is no any attenuation happening. Compared to high frequency, you have attenuation of the amplitude. In high frequency jet ventilation, you have attenuation of both the mean air pressure and the amplitude. That's why it's more gentle. So there's attenuation happening, and like you can see, the curve is decreasing over time until reaching the alveoli. They have the alveoli here, and here is the machine. So the machine, the mean air pressure is decreasing, attenuated until reaching the alveoli, and also the amplitude is attenuated. This attenuation is a feature that making the high frequency jet ventilation is very gentle. The high frequency oscillator, the map is fixed, is not attenuated. That's why it's very strong machine for oxygenation, but the amplitude is attenuated until reaching the alveoli. But in conventional ventilation, there is no attenuation, definitely because the pressure is needed to deliver the big tidal volume. You should not get attenuation. If you have attenuation in CMV, it is a bad feature, not a good feature. You may have it, for example, when you have significant leak. Other features, other very important feature in high frequency ventilation compared to mechanical ventilation, conventional mechanical ventilation. In conventional mechanical ventilation, everything is linked. So the mean air pressure together with the tidal volume, together with the I time, together with the rate, all of them, they are making the mean airway pressure. So PEEP plus the PIP plus that I time and tidal volume, they are contributing to ventilation and oxygenation in combination. So any one of them decreased or increased will affect both ventilation and oxygenation. But high frequency ventilation is different. There is the decoupling principle. When we have oxygenation is mainly controlled by MAP and FI2. Ventilation controlled by either amplitude or frequency. So that's might make it a little bit easier when you have high CO2 or low CO2. Yeah, definitely you increase or decrease amplitude, and rarely you play with the frequency. But when you have issue with oxygenation, either to increase MAP on high frequency oscillator or PEEP on jet ventilation, or increase or decrease FI2. So there's a decoupling principle difference between conventional and high frequency. Another very important physiologic feature for high frequency ventilation, that the ventilation is frequency multiplied by tidal volume squared. In conventional ventilation, the tidal volume is not squared. For that reason, the tidal volume is squared. Any change in the amplitude has highly dominance in ventilation. The amplitude itself, because definitely the tidal volume is affected by the amplitude. any change, even amplitude increased by 1 or decreased by 1, significantly affect ventilation. So significantly will affect the tidal volume because it is squared in high frequency ventilation. So when we to consider high frequency ventilation, assume you have infant not started on high frequency as a default. Again, we are doing that only in 22, 23 weeks. But beyond that, we consider high frequency as a emergency mode, a rescue mode, not a default mode. And if you have one or more of the following issues: oxygenation failure, when you have, for example, MAB more than 15, PEEP or PEEP more than 10, and FI2 more than 60%. Pressure limitations, when you have PIB exceeding 26 to 30 to deliver the preset tidal volume. You have very stiff lung. Or volume overload. You have significant volume. You reach at 5 to 6 ml per kg. And we are talking about assisted control during the first few weeks of life, because you may use higher tidal volume in SIMV in established chronic lung disease or evolving chronic lung disease. You may have anatomic rupture when you have air leak syndrome, like BIE or pneumothorax. Then using high frequency is much better to protect the lung from ongoing lung damage related to air leak. When you have severe BPHN requiring nitric oxide, when you have also significant lung disease contributing to that. But BPHN alone with normal lung, you don't have to start or consider high frequency or even mechanical ventilation. Sometimes you give nitric non-invasively. But we are talking about significant lung disease, severe lung disease, and complicated with even more severe BPHN. Patient profile, explain prematurity. Again, we're talking about 22 to 23 weeks as a default. Now, the difference between high frequency oscillator and high frequency jet ventilation, even if you don't have high frequency jet ventilation, just to understand the physiologic difference between both. So high frequency oscillator is much easier to use. It is available on most of the conventional ventilation machine as another mode. But high frequency jet ventilation is a unique, it's a really complex machine. High frequency oscillator, the strongest machine available is Sensormedics, which is now used mainly in PICU and older children, not being commonly used now in ICU. The reason that it's a very strong machine, it is positive in inspiration and expiration. So it is in inspiration pushing the air, expiration suck the air. So it is active exhalation, which might cause damage. It's very effective in ventilation for sure, but in premature babies, it can cause also significant damage. High frequency oscillator oxygenation strategy. How to set the setting. Set the MAB 2 to 3 centimeters higher than conventional baseline. So now we are shifting from conventional to high frequency oscillator. Increase MAB 2 to 3 above the baseline on conventional. Number 2, increase MAB by 1 increment. Don't increase too much because it's a very effective machine to optimize lung inflation. And you can rely on X-ray to have like the diaphragm. It can be flat in diaphragm. It doesn't matter, but the level of the lung at T9. Now we are using lung ultrasound to do so, but if you don't have lung ultrasound, you can still rely on X-ray. Number 3, confirm optimal volume via the fluctuation or the changes in SpO2. So allowing FI2 weaning, which is a priority now, on diaphragm expansion. Typically, you need to get the FI2 less than 60%. You don't have to wean in a high frequency to be room air or low FI2 because the infants are really sick. The success when you have FI2, wean below 60% to maintain target saturation. After that, maintain MAB and wean only when FI2 less than 60%. Watch carefully for overextension. So don't keep on high frequency for a long time. Once you have the MAB decreased to the previous level on high frequency and conventional, and FI2 below 60%. At this time, you consider weaning to conventional. If you are targeting to continue weaning until you extubate from high frequency, that's another strategy. Then you need to get FI2 below 40%. At that time, you can extubate directly from high frequency to non-invasive. High frequency, we're still talking about high frequency oscillator. The frequency, usually you consider 10 hertz. If you multiply 10 by 6, you will get the frequency or the rate. So 10 is the lowest number that you consider in very small brains, less than 1,500 grams. 6 to 8 in term infants with, for example, meconium aspiration. This is a concept on high frequency oscillator. And typically, the lower the hertz, the more chance for better ventilation. So start amplitude 2 to 3 or 2 to 2.5 multiplied by MAP. So if you have MAP, for example, of 10, you can consider an amplitude of 20 to 25. Visually, you confirm wiggling. So you can see the chest is wiggling or shaking. That's another way, visual way of considering that the high frequency is effective. And the most significant marker to confirm effectiveness is a CO2. When you have the CO2 normalized or back to acceptable level. Once amplitude reaches 3 or equal MAP, then you're stuck. Don't try to increase amplitude beyond the 3 times MAP. At that time, you may consider to decrease the frequency to get more effective ventilation. So again, on high frequency oscillator, decreasing hertz or decreasing frequency, you will get better ventilation because you will get higher expiration time. Now look at the jet ventilation. It is a huge, ugly machine. That's a description even from the manufacturer. It is a complex machine, and it is 2 parts. The top part here, you have conventional, which is responsible to deliver the MAP or PEEP. So PEEP is coming from the conventional, but the jet interrupter or the rate, the frequency is coming from this machine here, and the I time. So adjust the PIP, I time, and the frequency from this machine, but PEEP or MAP coming from the conventional machine. So there is what's called the high frequency jet pulses or pulse interrupter, and you have passive exhalation. So this machine is not the same like sensor medics sucking the air out of the lung. It is passive exhalation, which making the machine gentle. And it is really gentle to be used in very premature babies, and it is a default machine to be used in babies less than 25 weeks. And default to be used for the first few weeks of life until the infant is ready for extubation for 22 to 23 weeks. Rate usually between 240 to 660, but we never reach in our practice more than 400 most of the time. The inspiratory, as I mentioned before, the PEEP is coming from the conventional part, so it is tandem machine. It is combined machine, and there is a jet ventilation used primarily for ventilation. So oxygenation from this machine by delivering adequate PEEP and ventilation control from this machine. So there is 2 machines combined together, the conventional plus the high frequency jet interrupter or ventilator. And the first machine delivering PEEP or MAP, and we can consider side breaths or sigh breaths. So it is extra breaths on top of the high frequency. Usually we use 3 to 5 extra breaths. It is big breaths like sigh with high MAP to open the collapsed areas. To open the entire lung, we're using PEEP or PEEP escalation until we have the overall lung inflated. But if there is right upper lobe collapse or localized area of consolidation or atelectasis, we are using sigh or side breaths for a certain period of time, should be temporarily, not continuous for a long time. because it can cause significant lung damage. So the calculated map here is based on the PEEP from conventional ventilation and side breaths to most extent, and to less extent to PIP delivered by jet ventilation. In high frequency jet ventilation, there is what's called servo pressure. This servo pressure is kind of a meter to let us know about compliance. This feature is not available on definitely on high frequency sensor medics. The servo pressure will give you a number. And usually the number, we are following the trend. There is no specific golden number, but usually between 3 to 6. If the number is increasing, it means that the compliance is improving. So we may actually consider weaning. If the number is decreasing as a trend, it means that the lung is getting stiffer. So this servo pressure measures the flow power required to hit or set the PIP. The PIPs that you would like to be delivered, how much pressure or power needed to deliver that. So if more pressure needed, you will see the servo pressure getting lower. If the pressure is needed, less needed, then you get the servo pressure higher. So it means that you get a better compliance. Then we have I time. I time on high frequency jet ventilation. It is very effective parameter to adjust ventilation. By default is 0.02 second or 0.022. If we stuck on CO2 retention with the very high PIP, we now consider as a second parameter to increase I time, and it's very, very effective to get the CO2 washed. And the maximum that we can get I time on high frequency jet is up to 0.033. We usually don't consider beyond that. So just a general comparison between high frequency oscillator and high frequency jet ventilation. Exhalation on oscillator is active, but jet ventilation is passive. That's why it's more gentle. Airway pressure is constant, but in high frequency jet ventilation is attenuated or variable. Inspiratory time, usually variable, about 30% of the respiratory cycle, but it is fixed and short in high frequency jet. Again, it's 0.02 seconds and can be increased if we need to optimize ventilation. Best for homogeneous disease, RDS, acute lung injury, that's high frequency oscillator. But high frequency jet ventilation can be used for homogeneous and heterogeneous lung disease. If you have severe PPHN associated with severe lung disease like meconium aspiration, then you can use oscillator. It's more strong. Premature versus term babies. If you have a premature infant, definitely jet ventilation is the most effective machine. If you have heterogeneous lung disease, then jet ventilation. Still, as I mentioned, can be used for homogeneous since birth from the beginning for premature babies, but it is more effective in heterogeneous lung disease. Strategic evolution, early optimization of lung volume in atelectasis in prone position lung definitely is lung protective strategy. Use or choose high frequency oscillator for severe uniform lung disease. Use high frequency jet ventilation for non-uniform pathology or air leak later in life or in very premature infant. The pathophysiology is not static. Your strategy cannot be static. It should change according to change in the lung pathophysiology based on the X-ray, plug gases, lung ultrasound, and combined integrated evaluation. Now we'll come to the extubation. We manage the lung properly, and then we have the extubation planned for any infant on mechanical ventilation. Every day in round, you have to ask yourself, what is your strategy and the plan to get this infant extubated? We exclude from that 22 to 23 weeks until they are 4 to 6 weeks after birth. We continue keeping them on high frequency ventilation, and also excluding those with the other conditions that you cannot extubate, like for example, cannot breathe. There is no any spontaneous breath, so that doesn't make sense to extubate the infant soon. But you should have a strategy when you should extubate this infant. So at 7 days of life, and the other also exclusion, when you have infant during the first 3 days of life, less than 26 weeks, unless washing CO2. Why? Because if you extubate early, you will get the CO2 change, and this is a critical period for IVH. So during the first 3 days of life, below 26 weeks, gestational age, and if they have the CO2 reasonable, okay, it's 3 years of life, and then consider extubation. Now you reach 7 days of life. Again, the exclusion 22 to 23 weeks cohort. And the infant, you ask yourself, if the infant ready for extubation, if the answer is yes, extubate without hesitation to non-invasive. If the infant unable to extubate, although there is a chance the infant will require re-intubation, that's fine, but you have to give a chance. If the answer is no, unable to extubate, you need to identify the cause. If the cause is related to lung is really stiff, then you may consider a dexamethasone at the time. So you have now the target summary. As I mentioned before, this is a target to optimize during the first few days of life. CO2 40 to 65, saturation 88 to 92, brain saturation 60 to 80%, pH 7.2 to 7.24, hemoglobin more than 120 during the first few days, maybe up to 7 days if the infant still on mechanical ventilation. The 7-day rule, attempted extubation by day 7, except 22 to 23 weeks. The framework here, as I mentioned before, gestation age 22 to 23 weeks, high frequency plus hydrocortisone might be needed, especially if the mother did not receive full course of antenatal steroid. 24 to 26 weeks, assisted control on high frequency. 27 to 32 weeks, the default is non-invasive ventilation. If the infant is breathing below CPAP, you are in the right direction, unlikely to develop significant chronic lung disease. If the infant is apneic, on low ventilation requirement, optimize caffeine. If the infant is breathing plus high requirement of CPAP, breathing fast, then you need to recruit the lung. If the infant is apneic on high requirement, likely will require re-intubation. Infant not breathing and requiring high non-invasive ventilation, you may need to re-intubate for this baby. If you are unable to extubate and you are reaching 28 days old, then consider HEAD protocol for evolving chronic lung disease. If the infant more than 32 weeks gestational age, 32 and above, this is established chronic lung disease, so consider HEAD 2 protocol. And I will explain, I will show you what is the difference between both. But don't consider the HEAD protocol in infant with severe BIE or less than 28 days and still requiring high frequency ventilation, very high oxygen, very severe lung, very heterogeneous lung. So what's HEAD protocol? HEAD protocol, it is by evidence published that it is high tidal volume, low rate for chronic lung disease. So we give big breaths, like big tidal volume, and with low rate. So that will be helpful for the air to reach the areas with high resistance and poor compliance. Because the areas with low resistance and good compliance will get the air and will get overextension if you give too much rate and low volume. And you leave the areas with poor compliance unventilated. So this will give a chance with longer eye time and bigger tidal volume for the air to reach poor compliant areas and high resistance. So in the HEAD 1 protocol, the PEEP 8 to 12 sometimes can be higher. rate 20 to 25. I'm talking about SIMV protocol. Target tidal volume 6 to 8. And you can adjust the PIP according to their lung compliance to get the tidal volume delivered. I time 0.4 to 0.6 seconds according also to the rate. And the infant is breathing 20 to 25, but the infant might be breathing beyond that. Anything beyond that is unsupported. So that's why you have to apply pressure support for unsupported breaths. Unsupported means a spontaneous breaths beyond the 20 to 25 mandatory rate. Usually 6 to 10. 6 to 10, don't like give more than 10 pressure for that unsupported breaths. And you can see on the monitor that the spontaneous tidal volume is 4 to 6. So you may see on the monitor, if you are using, for example, Draeger or any monitor, you may get that very clear on the monitor that the spontaneous breaths is 4 to 6. That's a target. So you can adjust the pressure support to reach that target. And there's what's called slope. Slope is a gradual drop from the PIP to PEEP, not sudden drop. Usually we consider slope 0.05 to 1/3 of the I time. And that's easy to consider on or to adjust on conventional ventilation machine. So if you consider dexamethasone, again, because you are unable to extubate, the infant still on head protocol, unable to extubate, these are the criteria. The preterm, less than 28 weeks, more than 7 days of life, and invasive ventilation, unable to extubate. Check the ventilation central drive. If the infant is not breathing, you need to optimize the caffeine. That might be the reason why you cannot extubate. Check any upper airway issue. And how to check that? Look at the leak. You should have at least a leak between 10 to 30%. Otherwise, the airway might be tight around the ET tube. If you are suspecting pulmonary hypertension, then you have to consider T and echo for that. Check by lung ultrasound. It's a very sensitive tool to differentiate or predict chronic lung disease. If the score more than 10 or worsening, there's another reason to consider dexamethasone sooner. If the score less than 10 or improving, then the lung is not that severe, and you may consider extubation, unless you have other reason to give steroids like the airway is tight and there is no leak. If the infant ready for extubation, how to select the post-extubation modality? If the infant was mild lung disease with intact respiratory drive, you can use CPAP as a default and use one pressure above the PEEP on invasive mechanical ventilation. So if the infant extubated from PEEP of 9, use CPAP of 10. And then if the infant failed and could not really tolerate CPAP, then you can shift to NIBPV or nasal high frequency. If the infant on moderate to severe lung disease or unable or unstable drive or failed the previous extubation on CPAP, then extubate to NIBPV or nasal high frequency oscillator. NIBPV, the PEEP is 1 above the PEEP on invasive ventilation. Delta be 7 to 12 above PEEP. I time 0.4 to 0.5 second and rate 15 to 20. If you select the nasal high frequency, this is a setting. MAP 1 to 2 higher than the previous PEEP on invasive ventilation, amplitude 2 times MAP, and the frequency 8 to 10. This is a default, and usually we are not increasing beyond that. And the highest MAP that you can reach on nasal high frequency oscillator is around 14 or 15. Beyond that is really unreliable to deliver non-invasively to the lung. So this is the just a comparison between the setting on CPAP, nasal NIBPV versus nasal high frequency oscillator. So 7 to 8 at birth. Don't consider higher at birth because you have likelihood of development of pneumothorax, but that's not a condition in chronic lung disease. There is no like CPAP low level. We can use CPAP even up to 14 in severe chronic lung disease, post extubation. In IBPV, also 7 to 8, because you have a chance of development of pneumothorax, but you don't have that risk in chronic lung disease because the lung and the pleura is fibrotic. Pneumothorax is very, very unlikely to happen in evolving or established chronic lung disease. So PEEP, again, one higher than the previous invasive, delta B 7 to 12, I time 0.4 to 0.5, and rate 15 to 20. Nasal high frequency, not being tested yet or used as a default in the delivery room. We haven't done that yet. We are still using that for chronic lung disease post-extubation. But we are using NIBPV in the delivery room. Lung ultrasound can guide you to wean CPAP at the end. That would be the last slide before I show you some of the useful tools online. Preterm infant on CPAP. We are using lung ultrasound almost daily or weekly to guide weaning CPAP. When we wean, usually we wean every 2 to 3 days if the infant is clinically stable. If the infant unstable, like requiring more oxygen or requiring or worsening blood gases, lung ultrasound is helpful to identify is it related to lung disease or not. If the score less than 6, then the lung is not really significantly affected. It could be, I'm not sure what happened. Can you still see the slide?
Yes, you can see it.
Yeah, it could be related to feeding or the infant is not breathing adequately. But when you have 6 to 10, usually maintain CPAP, the same or wean cautiously. If the lung ultrasound score more than 10 and the infant is showing signs of hypoxemia, definitely you need to escalate CPAP. This is how we deal with the CPAP guided by ultrasound. And this is actually published in the American Academy of Pediatrics and the Canadian Pediatric Society. Now, let me show you at the end the website. If you go to NeoPeds Academy, the website now is updated. It's a new website. And this website, you need to sign up for free. And if you had a previous account on the old website, what you need to do is just renew your password. And you will get continuation to use. So clinical tools here, you have so many tools here, and it's increasing almost every week. You can go by category, so go along here. So you have the neonatal chronic lung disease outcome estimator. So you can estimate the severity of chronic lung disease. If you would like to use the steroids, this is a steroids protocol that's beyond the DART. So all of the doses and the indication for each one of them with the specification about the protocol in this tool. And respiratory support in chronic lung disease, including the different protocols that we suggested, and it is in different languages. So you can select between your language, Arabic, Spanish, Turkish, Chinese, Mandarin. So select your specification, parenchymal predominant lung disease, or could be a pulmonary vascular disease. So you have pulmonary hypertension with chronic lung disease. So select one, and then you can start with the calculator until you help you to make a decision. So it is a tool to help making decision. Then they have the HIT protocol in details, HIT 1 and HIT 2, and how to initiate. And you have a lot of helpful tools just to save time. You can go through it. It's very self-directed, and you can use it without any issue. And it's free on the website. Now I'll stop sharing and happy to have your questions.
Thank you, Dr. Yasser. Really, I am very impressed with this presentation, which I feel that I'm regretting that I didn't make it like 2 hours, because myself, I have a lot of questions to ask you about this guidelines or this approach. And also I'm impressed with a lot of variation in practice between like here in UK or Saudi Arabia or Canada. I'm really impressed with this approaches. And actually, I leave the audience to ask question first. If Ali, a question can be made on the chat box if anyone willing to ask a question. But for me, I will ask first. Tell Ali, tell us who asks the questions. For you using hydrocortisone for babies less than 22 to 23 weeks, Dr. Yasser, do you observe any increase in risk of NEC for such babies, or there is no relation here? Especially we have this phobia of using steroids early and the risk of NEC.
Yeah, that's a very good question. So hydrocortisone is used in a lot of them, but not all of them. So you don't have to use it as a default, only if you have a reason. For example, you have borderline blood pressure, or the infant requiring very high setting, or like unstable hemodynamically, or you have significant risk of septic shock, for example, chorioamnitis, and mom did not receive his antenatal steroids. So you should have a reason. And if you use it, continue for 10 days. Don't like stop it in between. So don't use it in everyone. Regarding neck, the neck is associated with dexamethasone. That's why we're not using dex for the first 7 days. The other issue that I recommend, if you are using hydrocortisone, then you should not treat PDA. So that's one of the other issues that might happen and might making us consider don't use it for everyone, because you may need to treat the PDA. And if you use even acetaminophen, it might increase the risk of perforation. Not neck, it's perforation. It is increasing risk of intestinal perforation.
Okay. Ali, do you see any question in the chat? Because I have.
Yes, I can see the chat now. I can see many questions.
Yeah, you can.
So I just start from the bottom. It is better to keep a baby between 24 to 26 weeks on high frequency oscillator, then extubate. That's the question. Or better to wean to conventional. It is case based. The question asking, should we consider the same for 24 to 26 weeks to keep on high frequency or conventional? It is again case based on the lung. I saw before 26 weeks on NIBBV from the day one required missed and continue without need for intubation. And I have 26 weeks required high frequency invasive, and the lung was very bad. It is case based. The only default use of high frequency without any hesitation, 22 to 23 weeks, up to 23 plus 6, so 24 and above, then it is case-based. But if the infant is really with the bad lung from the beginning, below threshold, don't think too much about shifting to high frequency. If the infant just borderline CO2 is increasing, use high frequency. Don't be hesitant. And we do that because we have jet, we have the privilege of having jet, which is very gentle mode of ventilation. And when you have significant lung disease, a lot of factors that you may consider, and I advocate you to use a calculator for chronic lung disease based on the risk factors, including if the male infant born outside your center, transferred, no adequate antenatal steroids, or antenatal steroids was given a few weeks back, any suspicion of chorioamnitis. All of these factors will affect your decision.
Mm-hmm.
The question, there is a steroids question, 3 question marks. I don't know what that means, like steroids and the question marks.
Maybe asking about the timing. You mentioned if we baby still not extubated by age of 7 days.
So by 7 days,
yeah,
and the infant unable to extubate, then you start to consider steroids. Dexamethasone, again, DART is very minimal dose now. And the old fear that the steroids would affect the brain, that's kind of old thoughts. Is not really considered nowadays significantly. Only we consider the cumulative dose. When you give many courses, when you reach cumulative dose of probably more than 2.5 milligram cumulative dose, then you have to think about that. That's too much steroids. But if you give one course, even moderate dose, as per the protocol that we have it on the website, that's still fine. And we are supporting this protocol. DART is really mild dose. You may still consider it in mild cases. Excellent presentation, thank you. So that's a feedback, thank you very much. There is a question from one of the colleagues from Turkey. Is there any exact point for starting dexamethasone? Because today we are aware of their side effects. Yes, the question, the side effects on neurocognitive function is not the same as our thoughts before. The new studies does not show the same concept that we have more freedom to use it nowadays. With the restriction, the cumulative dose matters. And every day you keep the infant on mechanical ventilation, the impact on the brain is really significant. So you have to balance between both. So don't buy more time keeping the infant of mechanical ventilation for a longer period of time was worse than chronic lung disease because your fear about using steroids. So it is payback. So consider steroids, there's side effects for sure. Blood sugar may increase, the infant will be more agitated, may require more sedation. There is a risk on the gut for sure, especially if you use it early or we use it with other medications. But again, the ventilation is the worst thing that we do in premature babies, keeping them on ventilation unnecessarily. So it is like a kind of balance between both. Usually we discuss with the team as a teamwork because there is no black and white answer. And also discuss that with parents. Well, before we start the series, we'll let them know there's side effects expected, but we need to extubate the baby as soon as we can.
So if you allow me to ask one question before you read the next one, and I know you are very busy and you have to...
I have another presentation, so maybe one question and I need to shift because we have...
Okay, just you know, some babies develop PIE picture early and they are less than 28 days, suppose like preterm. And some of the babies who stay on ventilator for like, still didn't fill the criteria for chronic lung disease, but they stay like more than 2 weeks or 3 weeks on ventilator support, and they show PIE changes. Do you, at this time, do you decrease the PEEP or you consider HIT protocol, or what you consider if the baby is showing early PIE changes? And what is the difference if the baby or now having the chronic lung disease, but more atelectasis picture, and some of them had chronic lung disease, we cannot able to extubate them, but the picture looks like more hyperinflation picture. So what would be approach on such cases?
Yeah, that's a very good question. So we have to differentiate between false impression of hyperinflation. When you have significant PIE, significant interstitial air leak syndrome, and we'll see the lung is really like very distended in the X-ray with flat diaphragm, that's a false impression of hyperinflation. This is not because of you are giving too much pressure, because the lung is bad and the lung is PIE interstitial. If you reduce the PEEP, you will get even more worsen of the lung ventilation. In this case, we are dealing based on the blood gas and the oxygen requirement. If you reduce the PEEP or MAP and you see worsening of oxygenation, means that you have to increase it back. You have to keep the lung recruited. Even if you see in the X-ray, the lung is significant PIE. In this case, the high frequency is the best modality. When you have severe interstitial leak syndrome, heterogeneous, we are using again jet ventilation, especially with the oxygen more than 60%. Yeah, the infant is not yet ready for HIT protocol. Oxygen more than 60%, CO2 still more than 60 or borderline high, and the severe PIE picture, then the lung is really bad. So keep the infant high frequency until you get the FI2 less than 60%, preferred less than 40%, and able to wean the pressure. So if you have the infant requiring MAP, for example, higher than 15, and PIP and jet ventilation, because you are using PIP, not the amplitude, the PIP is still more than 25, then the infant still requiring that jet ventilation. So multifactorials, blood gas, FiO2, and how much pressure needed, and the lung, how much affected as PIE. And the picture that you described, the best to keep the infant longer on high frequency ventilation.
Okay, thank you a lot.
And you may consider steroids if the steroid is not started.
Yeah.
then definitely you need to stop the progression of chronic lung disease by using steroids.
Really, I'm so impressed with this presentation, and I feel that we need to repeat it again because I think we have a lot of questions. And if you be happy to have another session for such same topic, it will be really too much appreciated, Dr. Yasser.
Yeah, with pleasure, no problem. We can repeat that in the future again.
Thank you. I know some audience joined very late, and we started on time because Dr. Yasser is busy and they have to attend another meeting. Too much appreciated, Dr. Yasser, that you always responding to my invitations. Is so kind of you. And thank you everyone who attended the session. And we promise from my side as Tara Neonatology Group to have more webinar with Dr. Yasser, and you have too much knowledge to gain from Dr. Yasser. And thank you so much for the NeoPeds Academy. I think a lot of free things. We will try to use it. Thank you a lot, Dr. Yasser.
Yeah, it was a pleasure at any time. And I think you really recorded the presentation, so you can share it with everyone.
Yes, Ali, you want to say something?
Thank you, Dr. Yasser. Thank you.
Thank you.
Yeah, you're welcome. Thank you for your support.
Thank you. Thank you.
Thank you, everyone. Again.
Thank you.
I'll echo Senator Johnson's comments about your opening statement, Mr. Chairman. I think it was dead on. Very, very well done. Mr. Fauci, do you know who David Schertler is?
On the advice of counsel, I respectfully decline to answer based upon my rights under the Fifth Amendment to the Constitution.
Fifth Amendment of the Constitution. What does the Fifth Amendment of the Constitution say?
On the advice of counsel, I respectfully decline to answer based upon my rights under the Fifth Amendment of the Constitution.
No, I'm just asking you what it says.
On the advice of counsel, I respectfully decline to answer based upon my rights under the Fifth Amendment to the Constitution.
I'm going to give the Constitution to my aide. He'll bring it over to you so you can have it for future reference. I think it's something that every American should know what the Constitution says. Do you know who wrote the Fifth Amendment?
On the advice of counsel, I respectfully decline to answer based upon my rights under the Fifth Amendment of the Constitution.
So you're invoking a right that you don't know who wrote it or what it says. Is that correct?
On the advice of counsel, I respectfully decline to answer based upon my rights under the Fifth Amendment to the Constitution.
Wow. All right, let me tell you who David Schertler is for the audience because he was ejected by the chairman. He's a high-profile criminal attorney. He's represented some really great people, like Senator Bob Menendez. Maybe that's somebody who my Democrat colleagues may remember took gold bars as bribes from the Egyptians. And there's an article here in the Washington Free Beacon that talks about why you would hire a guy like David Schertler. And the comment is, if you're in deep shit, that's who you call. Do you feel like you're in deep shit?
On the advice of counsel, I respectfully decline to answer based upon my rights under the Fifth Amendment to the Constitution.
Clearly, what you think today is that somehow you're above reproach. Somehow you feel like you don't need to be treated like a normal American. Can you do me a favor in the audience and stand up if during the time of the COVID pandemic, you were called a racist for calling the virus a Wuhan virus or the China virus? If you thought the 6-foot rule was total crap, if you thought the vaccine wasn't something that you should take, if you thought it was out